Good morning, everyone. Oh, I'm nice and loud this morning. Nice to see you all here bright and early. I hope you had a fantastic night at the dinner last night if you were there. I'm so happy to kick off today, the last day of the conference, with this session. It's very dear to my heart. My background is in community development. I worked for local authorities in Ireland before moving to London and getting involved in health policy. But my roots are very much in community background. I was lucky in this conference to get the opportunity to work with Danny Power, my co-chair, who has been an absolute aid to the development of the conference here in Belfast. And over the few days before the event, I was lucky enough to go and visit many community projects around Belfast. So the videos that you're seeing at the start of the plenaries are ones that myself and my colleague David Lenan had a chance to visit before the conference. A huge and important work going on in the community in Belfast. So not to eat into anybody's time, because we have a lot of presentations to go through this morning, I'm going to introduce my co-chair, Danny Power from Belfast Learning City. Thanks, Danny.
Fiona's told me I'm on a clock, so I have to put the timer on. For anybody who knows me, this will be a minor miracle if I manage to keep it to 5 minutes. I suppose, first of all, thank you for inviting me to be part of the conference. Just a little bit about myself, but hopefully not too much. I'm a community worker in Belfast. You may notice by the accent, it's not necessarily a local accent. I've been living in Belfast for around 40 years, originally from Scotland. First of all, I suppose I should just start by thanking all the international visitors for, first of all, for coming to Belfast, but for bringing the good weather with you. For those of you who came prepared with raincoats, I apologise. My role, as some of the audience, some of our hardest working GPs in Belfast are just sitting just in some of the early rows. That's Grania Bonner, the woman who's looking slightly embarrassed here at the moment. I have a multifaceted role in the city, but essentially I'm a community development worker. But today I'm kind of here as the co-chair of Belfast Learning City, which, for those of you who don't know, is a UNESCO designated learning city. It's part of a global network of learning cities. We have 354 cities in the network across 77 countries, and we work quite closely together. So it's a vast kind of depository of information and advice and guidance. So that's kind of why I'm here. We have 6 learning cities on the island of Ireland and 10 across the UK. And Belfast, in its unique political perspective, can tap into both. I suppose I look forward to hearing some very interesting approaches and success stories that address the core thinking behind this conversation. I should say at the start, we're all part of communities, and many of us are also signed up to designing and delivering public service support, particularly in the arena of health and social care. However, people's lives, as we all know, are not separated into nice, neat planning boxes. So what happens in their health life is affected by their education, by their environment, by their economic circumstances, and many other issues. So therefore, to build lasting and sustainable resilience across our communities, cities, and countries, we need to do things in a different way. And just like to say a little bit about, some of you will have known and read the work of Professor Robert Putnam, who in his book in 2000, was based on his previous papers, he talked about the decline of social capital in America from the 1950s onwards. And he talked about the decline in social discourse which found Americans educating and enriching the fabric of their lives. And he essentially put forward the idea that the core idea of social capital theory is that social networks have value. People coming together have value. So in the context of that and that understanding, I believe we need to understand and develop a resilience-based population health approach, which puts accountability and responsibility to the fore, and which aims to improve the health of our communities, to enable resilience and embed well-being, improving the physical and mental health of well-being while reducing health inequalities. I have loads of pages, but I promise you I'm not going to read them all. A population health approach would create a collective sense of responsibility across many organisations and individuals, in addition to health specialists. It is not to confuse it with the phrase population health management, although widely used and often heard with a specific meaning which is narrower in focus than population health. Population health management refers to ways of bringing together health-related data to identify specific populations that health services may prioritise. Population health planning, in my understanding, brings together people to look at how you improve the quality of life with people at the forefront and centre. We have increasingly complex communities, and we need to understand the dynamics to those approaches. We need to develop a sense of identity, commonality, and spirit across our groups of people. New relationships are developed between communities and public sector bodies by community engagement, which build trust and make joint action possible. There is, through community engagement, more influential community participation in community-based led social or economic development activity and the way public authorities design and deliver services. We require a new proactive relationship which moves away from focusing on what doesn't work. And in some cases, we've actually forgotten, when we focus on the problems, that we also need to focus on the good work that happens and do more of it. So better engagement, for me, leads to better outcomes. And clearly, I'll finish with, to reduce demand, we must keep people well and for longer. So therefore, the issue of community engagement leading to better outcomes is not just a nice thing to do. It should be part of the core planning processes, which actually empowers people to take responsibility and essentially hands the power back to them, because I do believe that what we've done is we've disempowered by providing things for people, doing things to people, but we haven't actually, in broad terms, included them in the process. So that's just a couple of thoughts to try and hopefully provoke some discussion later. I look forward, we're going to take some questions, and then I think we're going to open it up to yourselves. Thank you very much, folks.
Thanks, Danny. You're going to be really inspired by our presenters this morning. We've done many meetings in advance of the conference to discuss what the session would look like, and I'm truly inspired by everything I've heard so far. But we'll start off with Sumit Sutty. Sumit's coming to us from Toronto, and she's going to talk about diabetes initiatives with the First Nations.
Good morning, everybody. I'm going to be talking about an initiative with the First Nations communities in northwestern Ontario in Canada. But before I start, I thought I would just do a quick land acknowledgement. The work that I'm doing in Northern Canada is based in the Americas, or in North America, which is Turtle Island. But being here in Northern Ireland, I wanted to acknowledge the land here, and I wanted to say that I acknowledge and appreciate the knowledge, wisdom, beliefs, teachings, languages, help, support, love, care, and traditions of the many ancestors who have been on the land known as Turtle Island, as well as this land, since time immemorial. I'm going to be talking about, on behalf of my team, about this work. I just wanted to acknowledge as well the large team and all of the time that's been put in to doing this work. I co-lead this work with two colleagues. They're both First Nations leaders, Janet Gordon, who's the Chief Operating Officer at the Sioux Lookout First Nations Health Authority, and Ralph Johnson, who's our elder. He's a natural healer, part of the natural healing program in Sioux Lookout. Myself, I'm a family doctor based in Toronto. I've been working in northwestern Ontario for over 20 years. I'm also a researcher with the Department of Family and Community Medicine at the University of Toronto. Just to give a little bit of context, we're talking about Northwestern Ontario. Ontario is basically, there's a lot of Canadians here, so basically East Central Canada. The area that I'm talking about borders the land between Hudson Bay and Lake Superior. The Sioux Lookout area has about 33 communities. The majority of them do not have land or road access. There's three or four that have road access in the summer, and because of ice roads, there's another 5 that have road access in the winter. Aside from that, these are very remote communities. The population of the 33 communities is about 30 to 35,000 people. When you talk to community members, they talk about being on the land, so I wanted to share what it looks like to be on the land in Sioux Lookout. The traditional foods generally involve fishing, hunting, berry picking. That's one of my favorite things to do in August. And then some of there's a lot of lakes, and one of the roads there in the bottom corner, that's one of the roads to that's year-round to one of the communities there. The work that we're doing is around diabetes. So again, just to give a little tiny bit of context, diabetes in First Nations communities, especially in the north, there is a disproportionate burden of people living with diabetes. The prevalence of diabetes is somewhere between 13, 14, 17% for people living on reserve, so people living in those remote communities, compared to the general population. For the non-Indigenous people living in Ontario, it's 5%. The prevalence also translates downstream in terms of diabetes complications, morbidity, and mortality. The bottom graph there shows the rates per 100,000 of lower limb amputations. Sioux Lookout is known as the amputation capital of North America, if not the world. The dark green line shows that the prevalence of amputations has been increasing over the last 10 to 15 years. And then the blue line actually shows a decreasing prevalence in the general non-Indigenous population. So we are talking about sort of a very high burden of illness and disability. This is basically, diabetes isn't the only condition that is disproportionately high amongst First Nations people in Canada. Many people, most of the people that I talk to, attribute this to root causes around the determinants of health, based in the difficult relationship that the government of Canada has had with First Nations going back many generations, around colonial ideologies based in racism, colonial governance, loss of land, culture, and loss of power. So one of the first things that the team and I worked on was developing a shared vision to work on diabetes. And basically, the initiative, we call it the Diabetes Connections Initiative. In the local language, it's called Shukowapi Pinawin Mamau. It doesn't translate completely into Diabetes Connections. It translates into we are all coming together to work on diabetes. The shared vision is around improved health and well-being, so not just for diabetes, but for overall health and well-being. Really the goal of the work is to empower communities to have autonomy and ownership for responding to the diabetes crisis in their own communities, and as a pathway towards being empowered to address all aspects of health. Basically, this work has 2 components. There's an implementation component as well as an evaluation component. Basically, the implementation component primarily is funded by both the federal and the provincial governments, as well as family foundations and other funders. But the work is to co-design and collaborate to support different models of care for diabetes at the community level. And through the work that we've done, we've identified a couple of key areas together with community members, leaders, as well as regional policymakers and decision makers to focus on to achieve this. And basically, the four implementing areas are supporting community healthcare workers, people that stay and live in the community. You can imagine in these remote communities, healthcare workers come in and out generally, but community healthcare workers who are from the communities, who stay in the communities, need quite a bit of capacity and support. The second aspect is improving the quality of care through integration, specifically at the service provision level, but also at the governance level and other levels. The fourth area is amplifying community cultural and traditional strengths. And the last bit, which we've heard a lot about during this conference, is enhancing community relevant data and digital solutions. There's also an evaluation component to this work, and we're looking at describing the different associations between a model of care across different outcomes around community wellness. Where for our outcomes, we're looking at the quadruple or the quintuple aim, as well as an implementation evaluation framework that comes from New Zealand, from the Aboriginal, some of the Aboriginal communities in New Zealand that look at sort of a more holistic and broad outcome-based approach to implementation that focuses on community engagement, systems thinking, integrated knowledge translation, and cultural safety and cultural connection. I thought I would describe some of our lessons learned with some of the quotes. I have 3 different lessons learned and 3 quotes that I've kept in my pocket from different community dialogues. And then I'll talk, hopefully I'll explain a little bit about the work and what it is that we actually do through that. One of the first lessons, and this was a lesson I learned about maybe 7 or 8 years ago, and I've carried it with me, and it's around relationship building, reciprocal trust. And an elder said to me, this work will progress at the speed of trust. And I think that's really, really important. I have a little timeline up on the slide there that shows that this work we've been doing together, I've been doing together with my team and the partners in Sioux Lookout, goes back to 2014. We're actually celebrating 10 years of working together, Janet Gordon and I, this summer. And this all started with a feasibility study back in 2014. And through that feasibility study, it was funded by a private foundation. At the time I was working with an ONG or NGO called Dignitas International. And I was actually doing community engagement and community healthcare worker training for the HIV response in Malawi and Southern Africa for decentralizing HIV treatment. And we looked and thought about being based in Canada as an organization. We felt a responsibility to see what kind of lessons we could translate to the Canadian landscape. And I came across Janet and her team at the Sioux Lookout First Nations Health Authority, who actually wanted to work with an NGO from an advocacy point of view. Because of the broken trust and difficulties with funding, difficulties with designing health systems that were culturally appropriate for First Nations communities, Janet felt at the time that she wanted to send a message to the government and to the world that, look, we need an organization that does crisis response and humanitarian work overseas. We want to bring them here to Northern Canada so that we need that kind of support, because the support that we have from our existing models doesn't work. So that was in 2014. Slowly we were able to build up a pilot program. We developed a community healthcare worker program. We had a number of setbacks between 2019 and 2022. The pandemic, of course, makes it very difficult to do community engagement, but as well, we had government changes in Ontario, in the province, that created sort of funding gaps and fragmentation of different services for the Sioux Lookout area. But then in 2022, luckily we were able to get some dedicated funding to have community conversations for co-creation. We spent a year doing that, and then we were able to be where we are today, where we have some sustained funding and support. My last two slides just are around some other lessons that we've learned. One of them is just around co-learning, and one of the community healthcare workers has said to me, we have a lot of knowledge to share, but we could certainly use some help with understanding the ways of the South, so acting as a bridge, basically. And these beautiful pieces of art were done by an Indigenous PhD student back in 2019, where she showed sort of the trajectory of integrated and disassociated care. So the photo with the eagle, or the art with the eagle, shows everything flowing, everything's integrated. That's the traditional way, how everything was integrated and flowing well. Then you see a woman in a box with people not even looking at her. That's the fragmentation and dissociation of care. And then she talks about rebalancing, and this is my last lesson learned. And you can see that the eagle's now flying, people are celebrating and working together. And I just wanted, my last lesson was around outcomes. How do we know that what we're doing is working? How do we know that we're doing it right? And one of the community leaders, actually this was Ralph, that said this to me. I'm also a researcher, so I talk about outcomes and design of studies and evaluations. And he's like, well, we know we're doing it right when we know that we're able to know and share how to live a good life. So we're looking very, very holistically at outcomes, not just what works for health systems and health managers and policymakers and funders, but also what works for communities. And on that note, I'll say miigwech, thank you very much. I look forward to the conversation.
Thank you, Sumit. And just a reminder, if you do have questions, you can put them into the app. Hopefully we'll have time left at the end of the session to go through some of your questions. So next up, I'm delighted to introduce Melissa McCallum. And Melissa is coming from the Greater Hamilton Network, which is a network that connects the community with health and care resources. So Melissa.
Thank you very much. My name is Melissa McCallum. I'm the Executive Director of the Greater Hamilton Health Network, which is one of the Ontario health teams which are really widely represented this year at ICIC. So I'm here to talk about our experience with building community health alliances over the last 3 years through our initiative through our Ontario Health Team. So Ontario Health Teams, at the heart of it, are responsible for driving integrated care across sectors, from primary care, acute care, and community care. It is a provincial government initiative. Right now, the full province of Ontario, which is within Canada, has 58 teams, and that's full provincial coverage. So we are one of those teams. Our network is responsible for approximately 700,000 residents. And like many that I've heard in these presentations over the last 3 days, we have intense sociodemographic health needs that include complex health and social issues, rising and increasing poverty, homelessness, mental health and addictions, a large aging population, and a mix of both rural and urban demographics. For the first time, we're seeing more seniors than youth within our geography. We also have unintentional drug poisonings, driving, premature mortality, especially in our age groups of 20 to 44. We also see racial diversity increasing, like many areas across the world. Our rural communities have migrant farm workers that come in during seasonal work. We also see decreased transportation in these areas and more of a hidden homelessness problem. So overall, within our catchment area, there are many different and diverse communities that we need to take into account when we're looking at driving integrated care. So how do we do this with so many diverse communities? And really, we hear this notion about shifting the power, but what does that really mean? And we keep saying this, but on the ground level, for us, this has really meant a few things, which I'm going to talk about in our experience over the last few years. But it really starts off with exploring and calling out traditional power structures. Locally and provincially, we have a very acute-focused environment. We also see different ministries plan across different care modalities. We have Ministry of Health, Ministry of Long-Term Care, Ministry of Housing. The structures can be very top-down. There's a historical maintenance of the status quo that we need to challenge on a day-to-day basis when we're working with communities. Many of the voices that we hear locally when we talk about the diversity within our GHHN is that many voices have actually been missing. This has led to inequitable funding across sectors, high funding going to acute structures, lower funding going into community, and that in turn is also causing a pretty drastic wage parity between those that are working in community and those that are working in acute. But what this has also led to is grassroots organizations, volunteer organizations popping up within our communities to fill the gaps that are not being funded or that are not being recognized by other power structures as being an important part of integrated care. So engagement with communities, as we know and we've heard many times, takes a lot of time. But this time does not always align to our government structures. A very real example is that, when we do have to get funding out, do we always take the appropriate amount of time to engage with communities that have not been heard in the past? This is a real tension that we encounter at our local OHT level. So one thing that we have tried to do over the last 3 years is create communities as foundations to be ready for when the changes happen. A call for funding or a proposal might be, a few weeks long, but how can we ready communities to come together to respond in a more nimble way, to elevate their voices for funding structures that have been pretty top-down, and doing that engagement work up front in order to create that foundation moving forward. So how did we do this, and how have we done this? And there's still so much learning to come, but we've taken the notion in our Ontario Health Team that inclusive relationships and partnerships are key. Our Ontario Health Team has taken the notion that we work with anyone. We do not work with just traditional health service providers that are funded from our ministry. We work with small organizations that provide food security. We work with volunteer organizations, housing organizations. We really are taking the notion that we need everyone to unite around integrated care, especially as, going back to that first slide, what are our communities facing and who needs our help the most? We truly believe that everyone has a place, and this is not just about traditional health service providers. Amplifying voices at engagements, we often take the place of who has not been here. Who has the community not heard of in the past? Who's providing work? And this goes down to, community engagement. Who's providing care to populations, to diverse communities that haven't been amplified at big engagement events before? Sharing this expertise, especially with those that have not had a platform, has been highly rewarding. And it's also created connections amongst acute and social organizations that haven't been there before. Decreasing funding competition is a major priority for us. Currently we have so many organizations responding to a call for funding. How can we actually get into a room together, call out the tension of maybe it's not going to be your organization this time, but plan as an ecosystem of care? Often our funding comes down in chunks, primary care funding, mental health and addictions funding. But instead of that being left to each individual organization to respond to the call, how can we be brave and come around a table and say, what does the community most need? And that might mean that your organization doesn't apply for this money. So this has been an interesting kind of concept over the last 3 years, and it's been highly rewarding for us to develop these shared funding opportunities. Another thing that this does is level the playing field. A lot of small organizations do not have the infrastructure to respond in a nimble, data-informed way to funding. And how can we actually do that as a group to amplify, again, those organizations that are doing incredible community work but just do not have the resources to respond? So we are really trying to shift away from competing against one another for funding to shared visioning, and we're trying to do this sector by sector for now. We see tremendous opportunity in new initiatives to get them right. And what I mean by this is that, it's sometimes more challenging to go back into the system and right some of the challenges and tensions, but we have an amazing opportunity with new initiatives to build equity as a foundation moving forward. And I'm talking about, building in equity data collection, race-based collection of information, language accessibility, and then use these as cases for future integration. So we definitely see the value and the positivity of working together in new ways to then set the path moving forward. And relationships over transactions. We see this a lot in the financial world. You build a good profit by having a good relationship, but I feel like it's the same way in healthcare as well. Healthcare can be very transactional, and it takes much more time to build those relationships. But how are we going to come together to ensure that those relationships are the foundation of trust moving forward so that we can start to address those real intense issues that were just discussed on the first slide? A few action examples of what we have been doing in our local area is coming together around low barrier clinic options. Identifying priority populations, like I spoke about on the first slide, assess those needs from a qualitative and quantitative lens. What are the stories that we hear from people within the community about where the gaps are? And then collating partners around the table to provide low barrier care in place-based initiatives. Going to where people are at, going to shelters, going to encampments, going to small community churches to provide care. We've done this in a number of areas in terms of identifying, again, populations that we're seeing adverse health outcomes and are using, more acute services ad hoc. How do we actually co-locate a model around where people are at? Over the weekend, we've just did this with the Sikh community while I was over here in Belfast, but we've served over 1,100 homeless women, homeless men, refugee, and rural older seniors by bringing clinics right to them. Prioritizing most in need, oftentimes we have this data already. The problem and challenge is acting on it. We've also have an intense lower limb amputation problem within our OHT. We focused on reducing the inequities around wound care, devices, even just language. When we started our lower limb amputation program, no one had ever collected race-based and language data on populations. It revealed that 50% of people within this catchment actually did not speak English at all. So we then retailored our programs to understand how can we bring language accessibility right to people that are accessing this program. Primary care expansion, this was a good example of bringing the primary care community, which had been fragmented in funding in the past, around the table to talk about, well, if we want to see investments into our community, how can we do this as one? Another example is understanding who the system actually already takes care of. A perfect example of this is cancer screening within Ontario. Most people with an address and an Ontario health card, insurance card, will get a letter talking and telling you about, you're up for screening, pap screening, mammogram screening. We focused our initiatives around who the system does not contact. And those people are oftentimes our houseless people, our communities that are living in poverty, and those not attached to medical homes. Again, how do we make it easier to screen populations by bringing mobile screening, I keep on saying screening, PAP pop-ups, and training workers, building in, again, language accessibility so that these things are easy to be met. Hotspotting and place-based interventions are a key part of our work. Again, we have data that shows life expectancy differences of over 20 years between our neighborhoods. How are we going to rectify that with interventions that come right into communities? A very interesting thing that we're also doing is rolling out health boxes. Again, when we go back to the opiate poisoning crisis, where do we see kind of these hotspot areas of overdoses? Over the next few months, we're putting in 24/7 vending machines for harm reduction supplies in those areas. And lastly, none of this can be done without building inclusive board and committee structures that include people with lived experience, the patient voice. We do not start a working group without lived experience. That is a core and key component to even start work under our Ontario Health Team. So I think I'll leave with our socials. Please stay in touch and happy to connect. But one really important thing is that, despite government structures, policy, and politics, I truly believe that there is nothing that stops us from a local level from coming together and working together to solve some of that. And it's been an incredible opportunity. So thank you.
Thanks, Melissa. And Melissa and her team are a former winner of the Integrated Care Award very early on in their journey, so it's great to see that continued learning. Thanks, Melissa. So next we're actually going to go to Queen's University, not in Belfast, but actually again in Ontario. And Amrita Roy is going to be coming live through Zoom. I hope if she's ready. And Amrita is going to be talking about lessons from Indigenous communities. Here she is. Welcome, Amrita. Over to you.
Hello, thank you. Can everyone hear me okay? Okay, I'm hoping that's a yes.
There you are, we can hear you now.
Okay,
Thanks, Amrita.
Perfect. Thanks very much. Excellent, so thanks again for having me, and apologies that I couldn't join you all in beautiful Belfast. I appreciate being zoomed in as an alternative. So my name is Amrita. I'm a family physician in Kingston, Ontario, Canada, and a professor and a faculty member and a researcher at Queen's University in Canada. I am not Indigenous. I'm a settler. I strive to be an ally by working collaboratively with Indigenous communities in research projects such as this one. So I'm thrilled to be here today to share some results. See if I can make my slides move here. There we go. Of this research that we're doing in the new Frontenac, Lennox, and Addington, Ontario Health Team. I presented some of these methods actually a year ago back in Antwerp, and I'm thrilled to share some results today around this question of what does meaningful collaboration look like between Indigenous communities and partners and Ontario Health Teams undergoing health systems transformation. So to offer a bit of background, health systems in Ontario have been restructured into these entities known as Ontario Health Teams, which are premised on integrated care and are driven by the quintuple aims. The fifth aim, of course, being pursuing health equity. In southeastern Ontario, which is where Kingston is, and sort of Kingston and the surrounding regions, is the Frontenac, Lennox, and Addington, Ontario Health Team. So that came together with numerous clinical and community partners, including local Indigenous health groups. So Canada, of course, is one of the countries in the world that has a colonial past and a colonial present as well, frankly. And so accordingly, Indigenous peoples in Canada face health inequities that are driven by colonization and systemic racism. Correspondingly, improving accessibility, cultural appropriateness, and cultural safety of health systems are essential. And to ensure that the unique needs of Indigenous peoples are met, there should be a collaborative participatory approach to planning and executing Indigenous-specific evaluation activities with Indigenous-specific performance indicators. And so this research that I'm sharing today has two objectives. The first is to co-design, implement, and evaluate a governance process for collaboration with Indigenous communities for certainly health systems transformation, but also Indigenous-focused evaluation of activities of the FLAOHT. And then from a research perspective, to nest the above into a case study of the FLAOHT, examining processes for centering Indigenous perspectives and priorities in systems evaluation. So there's a couple of sort of main expected research outcomes that we hope to end with once we reach the end of this study. The first is incorporation of Indigenous specific evaluation activities for FLA-OHT projects. So that won't be the focus of my talk today, but at the last slide that I'm going to be showing at the end of my talk, I do have a QR code for a toolkit with Indigenous specific indicators that we produced as part of the broader work for this project. So it was created for FLA-OHT use, but we hope that it will be useful for others as well. So please feel free to download from that QR code when I get to that slide. But the focus of my talk today will be the second objective, which is a framework to operationalize collaboration between Indigenous partners and mainstream health systems in the co-design and co-execution of health system evaluation approaches that reflect Indigenous perspectives and priorities. And so briefly with the method, so this research took, or is taking, an approach based on community-based participatory research, and also based on the principles of OCAP, which stands for Ownership, Control, Access, and Possession, which is a set of principles around ethical Indigenous health research. Correspondingly, the research team is quite diverse, and there's multiple people from multiple parties coming together in the co-design of all aspects of the research. And that includes Indigenous members of FLA-OHT working groups and tables, other partners from the region's Indigenous communities, Queen's University researchers who sit on the FLA-OHT's evaluation support structure, which is called QUEST, and other FLA-OHT members. The broader study, or the broader research project, is a case study, and so there's sort of multiple sources of data. But the data that I want to focus on for today's talk is interview and focus group data with current and previous Indigenous members of FLA-OHT working groups, tables, and support structures. So in terms of the governance of this OHT, there's various working groups and so forth. And in each of these groups, there's representatives from key parties, and one of those sort of key groups is Indigenous members. So there's 1 to 2 Indigenous members are sort of on each of these groups. So we spoke with both the current members and also previous members, so Indigenous members who started with the process but then did not continue, and took a qualitative approach to understanding, to hearing their experiences and gleaning from those experiences about what meaningful collaboration looks like. And so we spoke of the possible 16 such members, we spoke with 8, 7 of whom were current members. We were only able to speak with 1 who was a former member, which is unfortunate. And 2 of these individuals were employed in the health system at the time. And we were able to do member checking as well per qualitative research approaches. So moving right into some of the results, in listening to the experiences of these members, we were able to glean some ideas around barriers to meaningful collaboration. And these included things like feeling dismissed or ignored, tokenism, slow-moving work with unclear goals, a sense of the Indigenous community being burdened or being expected to be the ones to educate and advocate to advance Indigenous health, and having that fully on their shoulders. Costs such as time and energy that can dissuade participation, particularly when the goals of participation are unclear. Lack of clarity on OHT organizational structure, lack of accountability and transparency in terms of who is responsible for what with respect to advancing Indigenous health. So those were some of the things that we heard that felt like barriers to the collaboration feeling meaningful. On the converse side, there were facilitators or enablers that were identified, and that included an approach involving moving from sort of continual consultation to concrete action, recognizing time contributions with honorariums rather than expecting sort of volunteerism, having open minds, ensuring that participants have adequate background information so that they actually can contribute meaningfully, and ensuring that Indigenous peoples feel heard, respected, and supported. And so drawing from the interview data to come up with themes around this question of what does meaningful collaboration look like, there were sort of 4 key themes that jumped out of the data. The first is creating Indigenous spaces. And so that includes honoring Indigenous peoples and cultures in healthcare spaces, as well as creating spaces where Indigenous employees in health systems don't hesitate to self-identify. There was some discussion about hesitance to self-identify for fear of being overburdened with poorly supported Indigenous health-related work once identified as an Indigenous person in the health system. And then there was also some concerns around the lack of acknowledgement of diversity within Indigenous groups. And one of the possible actions that were identified within this theme was the creation of a designated Indigenous table for the OHT, where Indigenous representatives can come together and connect instead of being sort of scattered across the various groups. Second of all, increasing Indigenous representation, and that includes things like hiring more Indigenous individuals to do the large amount of work required in health systems to advance Indigenous health. And also being thoughtful about, again, representing that diversity within Indigenous groups in the region. What also came up was the need to honor time and contributions through honorariums or other compensations instead of expecting volunteerism. That also came up as well. Thirdly, focus on relationships. So this theme highlighted the importance of genuine relationship building that is premised on allyship rather than tokenism. And then the final theme, was drawing on previous work, which emphasizes the fact that there's actually already been a lot of work that's been done already. There's been extensive reports, recommendations, research that's readily available locally and nationally that can be used to sort of inform action on Indigenous health, and that can facilitate moving from what can sometimes feel for Indigenous peoples like continual consultation, to moving away from being stuck in that consultation mode to actual concrete action. And so thinking about kind of the ways forward for the FLA-OHT, but potentially also for other organizations, if we were to learn from what we're seeing in our OHT to other OHTs and other institutions, these would be sort of these ways forward. So focusing on relationships, increasing Indigenous representation, creating Indigenous spaces, and drawing on previous work. And so a few conclusions in my last sort of minute or so. Action-oriented engagement, adequate funding and resources, and responding actively to Indigenous voices are key steps to ensuring that collaboration feels meaningful to Indigenous partners. This research is seeking to create a framework to operationalize what meaningful collaboration between Indigenous partners and mainstream health systems can look like. And our hope is that in addition to helping the FLA-OHT forward, this framework may be broadly useful to guide partnership processes between mainstream institutions and Indigenous groups in other sort of contexts of health systems and policy. So the next step here for us is that we're actually going to be now doing focus groups with the FLA-OHT leadership to figure out sort of ways forward. But I'd like to very quickly just acknowledge the various members from the Indigenous Health Council, Queen's University, and the FLA-OHT who are working towards this work. And again, apologies that I couldn't be there in person, but please see my email address on the screen, as well as that QR code that I mentioned as well. Thank you.
Thank you, Amrita. Not easy to present remotely. You've done an excellent job and great timekeeping, and you're going to stay online for the questions, so thank you for that. Next up, we have someone who's familiar. If you were at the plenary session yesterday, which I really enjoyed, we've got Amrita Maxwell coming from Think Ora, and she's going to talk to us about their work around primary-led integrated care.
Atamarie, good morning. It's a privilege to represent Aotearoa New Zealand, and I am the Chief Executive of Think Ora, a very new role for me, but an exciting one because that makes me a little closer to the front line. I have to preface my short, I'll try and stick to time, presentation with the fact that I'm deeply, deeply passionate about communities like many of us are here. And I'm loving the learning from this conference and some of those shared themes that are coming through. And, I guess it's mobilizing us to take action, as I guess is what I'm taking from this. So also as a precursor, I'm not an expert in terms of the subject that I'm about to cover, but more of a bridge builder, and really to drive health equity from some of the common themes here, but also what is happening in Aotearoa, New Zealand. My specific focus is, as part of this overall empowering communities to lead change, is around taking a social investment approach in Aotearoa, New Zealand. And it's a topical conversation at the moment with our change in government. So towards actually achieving social impact. Now, this little nice diagram actually gives you some of the ingredients of social impact, or at least some of the readings that I've done. These are common ingredients in terms of working towards creating social impact. And there's many of them, and it is a complex area. So why social investment? This movement isn't new. Certainly across the world and within Aotearoa, New Zealand, and it is an idea of using the data and evidence to target social interventions more effectively, with a focus on achieving better long-term outcomes for individuals and communities. It emphasises preventative measures and early intervention to address social issues. It takes into account health influences on all aspects of life and the factors that contribute to health. My lens over this was, okay, social investment. It is a real analytical lens on trying to measure the change we're trying to make in our communities. And some of the equation aspects that I put together was, we need that social innovation, and we're hearing lots of that as part of this conference. We need the investment, which will equate to the social impact. With the social innovation involving those new solutions to social problems in our communities, while social investment, as I say, is that we need the dollars to actually do and deliver, and together that will create the impact that we need. What is really important is acknowledging that to create that social impact, we need that cross-agency collaboration, and we've heard a lot and it's a real common phrase now, is that collaboration moves at the speed of trust, and it absolutely does. And I think it's just worth recognizing that. I want to also touch on the data, because data is king, and we measure what matters. And if we do that, we might get the change and improvement that we actually desire. But getting the data isn't easy. I think those of us that work in either community organizations or meso-level organizations, it's costly, it's timely for small organizations. And the questions around whose role it would be to create the social return on investment calculations, that is something that I think is playing out right now, certainly in our country, and there'll be many of an economists, and I've talked to a few in New Zealand, that are working through this. So I'll watch with interest to see how we move forward with that. I want to get to some practical examples, and I'll move a bit more at pace now. One of the social return on investment reports that I had the privilege of being close to the person who ran this initiative, Dave Latelli, a real community champion for change, comes with his own story. I encourage you to check him out on LinkedIn. He's very communicative in terms of his journey, his history, the storytelling aspect of his background, and what drove him to make change and create an initiative which really brought about support for those with morbid obesity, and creating a gym and getting people exercising, getting people into jobs. And he worked with partners to actually do that calculation of, for every dollar spent, $13.50 was saved within the system. And so hence more funding came. But for everyone to try and do those reports, it's actually not that feasible. So how we get past that issue is something that I say as I watch. But it was fascinating to get the results of this, and it is amazing work, and it really is having an impact. I want to just quickly focus on the capturing the whānau voice side of things, or the family voice, and taking that sort of social innovation lens and creating the solutions for impact. Because if we can't get the data to measure, the next best thing, or the best thing, is actually listening to our communities and seeing what the change really is and how it's working. So here is an example of an initiative, Horowhenua Takiwa, or locality or region, that's or Rohi as it's called in Aotearoa, and they really did take the leap. And it is a case study of one of the prototype localities in Aotearoa, New Zealand. And whilst there's some change in that space with our new government, place-based planning is still alive and well, and this is an example of that. And this is an initiative that is led by two iwi, two tribal groups, Mopoko and Rokawa, and they've given me permission to share this story because it is their story within their community. And they laid the foundations for connection with organizations and families who had strong existing relationships built on trust. A Māori approach, or kaupapa as we call it, also underpinned the values, the ways of working, and the places, the spaces, the approaches to hear the voices of those who often did not have the opportunity to speak or be heard. So Yumiko Oliver was the project manager for this locality prototype, and she recognises that the critical part is that whānau, that family voice. And I have the privilege now to be working with her in my organisation and still linking with our iwi as well in terms of real partnership. So what has been shared with me is the actual on-the-ground engagement that took place, and going to places where families and communities are, so meeting them where they are at, and taking the time and space to talk, listen, and reflect back what we're hearing. They ran wellbeing sessions in rural communities, they met in schools, there were Pacifica hubs, and for the intellectually diverse, there were learning spaces created. They held workshops, one-to-one interviews, and used creative techniques like collage to support the voices. There was an exhibition, Whakarangomai community exhibition, as I say, supported and led by Mopoko Tribal Authority and Rokawa Whanau Kaimahi or staff. They sat at stations and they listened to the people and they responded and they captured the stories. And so this is the photo of the exhibition, and they took some voting via the beads to gather what was important. And this was I went to this exhibition and I was absolutely in awe of the community development approach that was taken, a true community engagement. And it's not new, but it was great to see it alive and well in health. And so they had an aspirations, or a moimoa, as we'd call it in Aotearoa, tree, and they just really captured the voice. One of the highlights that came out as a real early action, and this was being able to take the voice of community and the listening and understanding to go, we're going to take some action based on what you've told us. And this was a mobile health clinic. So one of the superstars from the engagement, and they found that when they went out to the rural areas, the families were so grateful and began asking for regular visits of wellbeing services. And the mobile clinic goes out once a month and provides services from ear to eye checks to hairstyling. Practice Plus, which is a virtual telehealth service, was also highlighted as an after-hours telehealth service that provided better access for our families, and it was really appreciated. So increasing both access and support to Practice Plus was really one way of improving access to care. What they ultimately came up with by listening to community and engaging were the priorities, and these are the priorities at a glance, and these are owned by the community, and they really feel like they've been part of a journey that is ongoing. It's not standing still. So they tested that back with community just to make sure they heard right, basically. And again, through that interactive exhibition. So this, just wrapping up now, I guess what I was wanting to achieve here was linking, I suppose, taking that sort of complexity of social return on investment, creating social impacts, and highlighting the difficulty of measuring what matters, but then switching to if we just listen to our communities, we can actually take a very common sense, pragmatic approach, because I think we have the answers there, and we can just get on with the job, or get on with the mahi, as we would say in New Zealand. So the message here for me is, as I say, to prioritise the voice of community, take the action, and know that we need to take the leap in terms of the theme of this conference. So happy to answer any questions as we move forward into the panel, but thank you for listening.
Thank you, Amrit. An excellent thank you thing. Well done. So we're going to move on now to Wouter van Bessien, who's coming from the Flemish Department of Care. And we're going to move out a little lens-wise and look at a policy approach in Flanders. And we were lucky enough to be in Antwerp last year, so it's great to hear the continuing journey. Thanks, Wouter.
Good morning. I'm Wouter van Bessien. I work at the Flemish Department of Care in the team primary care, so we focus mainly on the organization of the primary care system in Flanders and Brussels. And it's a system that has been revised and revised over again. I was going to say we implemented some changes in 2010, but the people who went to the plenary session yesterday with Professor Jan de Mazenegger know that the healthcare system has been in reform since the 70s, and it's just an ongoing process that basically never ends. But what we have been doing since 2010 is basically starting to reform the ecosystem. So in 2020, we started to create local networks of healthcare providers, social care providers, local government officials, and citizens as well. And we wanted those partners to, one, be local, get close to the community, because if you're up there from a really high level, it's really hard to know what the needs of the population are. But we wanted those guys to really focus on how do we match the offer of healthcare, of social care, with the needs of the population, and how can we support those people in basically organizing their care. So we are building those local networks. You know, we're focusing on integrated care. We are bringing everybody around the table, and for us it's really important that everybody has an equal voice as well, because otherwise you get certain conflicts where people say, okay, this is tax funded, so there's some money going into this, and a lot of groups want a piece of the pie, and we need some system to make sure all the voices are heard. And so it's really about co-creating. Now, we're noticing, we started the system in 2020, then we had the pandemic, so we focused massively on vaccination, and now we are refocusing on those core assignments, and we're actually noticing that it's quite difficult, because you're asking local networks, not grassrooted, but basically government mandates from the government, to really look at the population, to engage with citizens, to co-create, to find what are the real priorities for your community, what are the things they want to see as well. And it's so hard, because we're getting signals all the time that people say, it's actually hard to find citizen representatives. It's even harder to keep them. And I think the hardest part of all is to actually make sure those representatives start to focus on the issues of the whole of the population, instead of just a subgroup, because that's what we're often seeing. Let's say somebody is a representative of people with diabetes, and it's all about diabetes. And that can be really informative, but you're talking about helping the population at a large scale as a government. So those zones they're working in are minimum 60,000 people, and you need to have some voices that are not organized. You need to have those voices heard. Let's say, for example, homeless people. If you're not listening, if you're not speaking with homeless people, how do you know what they need and how you can help them? So basically, it's a really hard challenge. Now, I'm not going to come here today and say to you that we have all the solutions, because we don't. But we started a process with stakeholders from both those primary care boards, but also patient and informal caregiver organizations and experts on participation to really have a good look at how can we promote the citizen participation in local groups while not taking away their identity, because you're basically forcing a structure upon them, and you need to have enough leeway so they can say, okay, we can work independently, we can make our voices be heard, but we can do this in a systematic way. This is a work in progress. So currently we're having workshops, we're having discussions, we're having one-to-ones with different stakeholders to see what we really need. Is our governance helping this or not? So I can already show you some main themes who are emerging from this work, but it's still very much in progress. So we basically need to do three things. You need to help communities or those local networks to choose priorities. I heard something here about like, let's get together instead of just all fighting for different funding. You really need to be able to create something that says, okay, what are the needs of the population? How do we get that in a system? How do we build policy on that? Then you actually need somebody to support that, because it's really easy to provide lip service to the idea of participation, the tokenism. I didn't know the word, but I think it's a beautiful word, and it often happens like that. So we need somebody to support, to check, and as a government as well, we need to build in support and evaluate the participation. Why do we need a model of priorities? It's basically simple. We're talking about taxpayer money, so everybody's jumping on the boat. And everybody has this amazing project that's going to change the world, and it needs to be funded now, probably yesterday. But it's quite hard, because you have a limited amount of time of people who are working in the organizations, so you need to select priorities. So we were brainstorming with this group, and this model popped up. Now, it's a UK model. It's not focused on healthcare. It's from the UK Design Council, I think. It's called the Double Diamond. But as we're visioning it, it basically forces those organizations to, from the start as the first diamond, to really start to look at everyone in your community. So not only data, because data always focuses on the people who are known, but also start talking with your providers, start talking with your citizens. What do you need? Where do you notice? Where is the low-hanging fruit as well? Where can you really make a difference without investing enormous amounts? So it's picking the low-hanging fruit as well. But so you're gathering all the data, you have your population analyze it as well, and choose some priorities. And in the next phase, that's actually the second part of the double diamond, you're looking at how will we form actions. Because I used to be a nurse, for example. I can probably build you an action. It sounds great for healthcare providers, and then you go to the community and they say it's ridiculous, it doesn't work, and the outcome is not necessarily what we want. So you really need to engage with your citizens really early and really often. It's the same what we did with the stakeholders as well. We said we're going to work on this, and we started to engage with them. Because if you don't do that while implementing it, how can you expect an organization to actually engage with citizens as well? So we have a model, but as I said, it's quite easy to say, oh, we're focusing on citizen participation, we're doing this for the good of the community, but the good of the community often is my own good. And that's something we're noticing really hard. Everybody's fighting for a little piece of the pie. So right now we're kind of looking like, okay, can we promote somebody or a group or an organization who actually focuses? You have been going on a process, you want to improve the quality of your participation, you want to listen to all voices. Have you been doing this correctly? And it's an important job, because then you're talking about power, because who's going to control the ones who control the participation as well. So that's something we're not entirely out of yet, but it's an important step in the whole process. Priorities, somebody to guard priorities. And lastly, we're asking a lot as governments. We're asking organizations to basically look very broad, gather a lot of information, select the correct priorities is really difficult. So as a government, we also need to support those organizations. That can be funding, but that can also be things like education, intervention, and so on. And that's something we really have to speak through with all those organizations. How can we support you on the long term so you're able to meet those goals? But at the same time, it's taxpayer money. So we're having to say to the people and to the politicians, okay, this is money well spent. So we have to find some KPIs. But the problem with KPIs is, if you put a KPI on a structure, for example, every local region is going to be different. Everybody is going to have a separate process, separate outcomes. So we need to find some KPIs to really focus on the process they're running through and not on the endpoint. And it's really hard. We're still brainstorming through this. We're doing workshops. We're thinking about this. How will we do those things? So, if I may summarize, there are 4 things I want you to take home with you. When you're working from a policy-making level, from a government-making level, start by engaging really early and really often as well. It's really important because you're going to ask those organizations to do the same with citizens, so you might as well start doing it from a governmental point of view. Then create a model of priorities because there's so much to do and there's so limited time and limited funding. So you need to select the correct priorities and focus the priorities on the needs of the people, appoint certain roles, who's going to check, promote the participation, and also, and that's done really from evaluation, look at the support, but also develop KPIs. And yet again, it's a balance because you can't, if people have to report all the time, it takes money, and that's time and money that goes away from actually helping in the community. So we're still struggling. This is open-ended at this moment. Now, if you have any questions, remarks, great ideas, we have the panel discussion. You have my email address over there, and speak to me in the conference as well, because I'm really curious about all your ideas. Thank you.
Thank you, Wouter. So last up, we have Pauline Ferzian, and Pauline's going to talk to us about a social medicine approach. Thanks, Pauline.
So first of all, I want to acknowledge our team at home of patients and healthcare providers. You are the heart and soul of this program. These slides have disappeared. Oh, okay. Hold on a minute. So you may have noticed that my co-presenter is not here. And I'm not sure where he is. So I'm actually going to be tackling some of these slides for the first time. And I am anxious for him. Well, actually, I'm concerned because it's very out of character that he's not here. So I'm asking for your indulgence so that I properly honor this program. So Dr. Andrew Buzari is really the innovative visionary of this social medicine program. He created it, he lifted it up. He's a brilliant young physician and policymaker and researcher. And I was along for the ride. I'm a senior advisor to this program and I'm a professor in the Department of Family and Community Medicine at University of Toronto. This is actually Andrew's slide, but I will be speaking to the converted when I say that we know the social determinants of health are a broad range of personal, social, economic, and environmental factors that influence individual and population health. In Ontario, where we practice, there are unavoidable and unjust health inequities that were really characterized before COVID-19, but were really accentuated during the pandemic. And that pandemic disproportionately affected low-income families, unhoused or homeless people, and segregated neighborhoods that the social medicine program is really trying to lift up. So the program is data-driven. We were able to see that 51 UHN patients had no fixed address, and they comprised over 1,500 visits in the same 6-month period. the cost analysis shows the cost effectiveness of supportive housing compared to what we have right now in our society, which are hospitals, jails, and shelters. Hospital ward, approximately $32,000, a jail, $15,000, a shelter, $7,500, supportive housing, $3,500. So we can see that a lot has to change. The social medicine at UHN, that program is multi-pronged, and it provides comprehensive, and I will say orchestrated, people-centered care, both in the hospital setting and in the community. It does that through 4 main services. So the first one is a stabilization site for people with substance use. And these are people who ordinarily would be taken to the emergency room because of acute intoxication. But instead, they are offered a place of recovery at the stabilization site and are connected to a range of supports. Next, we have trauma-informed support through peer workers in the UHN emergency room departments, and a health and social care model that is facilitated by dyads of nurse practitioners and community health workers who attend to people both, again, in the hospital setting and in the community. And then lastly, the most recent service is supportive housing. Through a partnership with the City of Toronto and the United Way, we are in the midst of offering 51 housing units to people who are the highest utilizers of UHN services. So some years ago, I attended the Salzburg Global Seminar where hospitals were featured in their role in building healthy communities. And I still recall the words of our Scottish colleague, Sir Harry Burns, who very much like what Danny, our co-chair, said this morning, talked about hospitals as institutions that act to do things to people, not necessarily with people. And certainly that was the perspective of UHN prior to the pandemic, but the pandemic gave us this unique opportunity to partner with a coalition of community support agencies, community health centers, to address people who are at the greatest need living in congregate settings. And it's really due to the foundational trust, the relationships that Andrew built with those partners that have just grown and really altered their perception and their cooperation and collaboration with University Health Network. They've become the anchor of this program because they really help us recruit and mentor peer support workers and community health workers to work in the program. So the peer support workers are people with lived experience who have experience with homelessness, mental health issues, and substance use. They provide a range of supports to improve the patient experience and healthcare capacity. So looking at analyzing some of the data, we see that in their interactions, 94% of the time, it's really about a friendly conversation or a empathetic discussion that really helps de-escalate potential risk situations. 84% of the time, it's giving out care products that people might need. 80% of the time, it's bringing their lived experience to really appreciate what the person's going through in the emergency room. And then lastly, 76% of the time, they're actually helping navigating just the emotions and well-being of that population. What we know about the population is that 45% of the clients have no fixed address, and they're referred to shelter beds. And of those 45%, 13% are in the shelter, 30% are homeless. So the emergency services now have brought a number of people to the stabilization center. They're given something to eat, a shower, maybe a warm set of clothes, and then whatever it is that will help them get back on their feet. It might be a cell phone, it might be a connection to a shelter or a community agency. And since its inception, we've managed to divert 2,500 patients from the emergency room. The model of social medicine that integrates health and social care does it, as I mentioned, with 2 nurse practitioners, about 12 community health workers. Referrals are made to community-based organizations, to harm reduction services. There's a fair amount of case management that goes on, trying to decipher what their medical needs might be, access to specialty care within UHN and beyond. And then, of course, the social supports cover a range of social and community integration, referrals for example, financial assistance, and so on. Integrating health and social care, you can see, has a lot of components, including just basic needs. Someone talked about the Maslow hierarchy yesterday. Really just a need for comfort, for safety, a roof over your head, community integration, dealing with food insecurity, and getting people involved in social enterprises. So sometimes we are helping people get back into the workforce. For people with substance use issues, getting them involved with harm reduction services, legal aid, and all of this is informed by our Standing Advisory Council. We have an Indigenous program coordinator, and we are consistently evaluating the outcomes of this program. So at the core are our patients who comprise our first lived experience advisory council, who are people who've been structurally marginalized and have lived with homelessness, substance use, or mental health challenges. And the intention is really to encourage their vibrant activity in the planning, the implementation, and the evaluation of every aspect of the social medicine program. They meet monthly. They are financially supported for meeting, and we do feel that their impact is really what keeps this program honest and on track. So we believe that the social medicine program is pioneering. There are a number of firsts. The first treatment for food insecurity during the pandemic, social medicine housing, providing 51 supportive housing units. I've mentioned the Peers and the ED program, and the social care model that's been integrated into the hospital setting, and that really looks to address 1,000 patients annually. And then, of course, diverting patients from the eMERGE each year through the stabilization site. Thanks very much for listening, and we welcome your questions.
Thank you, Pauline. A huge amount of practical advice given to us this morning. We're very close to the hour, so if you'll indulge us an extra 5 minutes, we might run till 5 past and give some time for questions. So I'll hand over to Danny. Thank you, Danny.
Okay, you hear me, folks? Now, for those who know me, no heckling. We've roughly about 10 minutes, I hope. We've a couple of questions that we kind of knew were going to come up, so we anticipated that you were going to ask them. And there are some questions through the app that we're going to try, there are a lot of overlap in the subject headings. So for the first question, I think we're just going to crack right in. For Amrita, who is hopefully sitting, well, she's not sitting behind me technically, but she is behind me. How do we move beyond the rhetoric of engaging communities to making it meaningful and to really impact improvements and outcomes. Do you hear that, Amrita?
I can, yes. Thanks very much. Hopefully you can hear me. I think that's a really important question. I think in the last few years, we've sort of seen this increase in conversations around equity and diversity and inclusion and indigeneity, truth and reconciliation, and community engagement, which is great. Those of us who've been doing this for a while, I mean, I remember 15 years ago as a PhD student being told to not use words like colonization and oppression in grant proposals because that would make them make it not politically palatable enough to get funded. So we're at a point now in the last few years where we're actually talking about these issues in a very normalized way, which is fantastic. But I think where the stumbling block comes in is when we're doing all talk and no action, right? So how do we move from having these conversations and engaging communities with these conversations to actually acting on them? And the reason why that's important is because there comes a point where, if all we're doing is talking with communities and listening to communities and talking more and listening more and consulting more and not actually acting, there's a point where it actually causes more harm than it does good. It becomes tokenistic. It raises questions of is this just a checkbox that we all have to fill in now, and at the end of the day, community consultation, I mean, the burden of that really falls to the community, right? Both in terms of time and also just the emotional and cognitive labor. So it is important that we don't just do community engagement for its own sake, but we actually do it to actually bring about change. And so how do we do that? Ultimately, that comes down to political will, accountability in terms of deliverables and action items, and at the base of that is resources. Is there funding to do the work that communities tell us that we need to do? Is there person power? Is there infrastructure? And is there a mentality of long-term planning? And reflecting on that in the context of the Ontario health teams, and not to be too cynical here, but ultimately for all that the Ontario health teams are being premised on this idea of integrated care and the quintuple aims and so forth, they were brought in by a Conservative government in Ontario to cut costs. And that has made it very challenging on the ground in Ontario health teams to do much because the budgets are small. It's sort of one-year funding structures, and that can be quite challenging. And we heard that in our focus groups with Indigenous community members around, we're not really sure what the point of all this is because we know that there's not a lot to go on in terms of having action. So, moving the needle really does involve actual investments beyond simply saying to Ontario health teams, you need to engage with Indigenous peoples and Francophone, which are the two special groups outlined. And so for what it's worth for FLAOHT...
Amrita, I might just stop you there just because we've only got a limited amount of time for our questions.
For sure,
but thank you so much. Thank you. Thanks, Amrita.
I would have listened all day, to be fair. I mean, obviously the questions follow on. A lot of the issues being raised are issues that people recognise in their daily challenges. So continuing that, I'd like to ask Wouter a question. How can you convince policy and purse holders to invest in and facilitate citizen participation?
Well, that's actually a hard one, because if you're working with citizen participation, you're actually posing a danger to politicians, because a politician is making policy, and so they're enforcing that. But what if the community actually says, like, it's a really crappy policy? So you basically have to step to policyholders and say, okay, we're going to provide citizen participation, we're going to provide the voice of the people, but it isn't hijacked by certain special interest groups, because that often happens. So you need to have the quality, they can see it. You need to promote this as basically a way of promoting democracy, because if they're engaging a lot with the community, they get better standing and they might actually get re-elected, which is, alas, often really important to politicians as well. And another advantage of having a lot of groups working in the community and talking to the community is that when you have things that happen which you don't have a policy over yet, and a perfect example has been the Corona crisis, for example, we had a lack of structures to really ask questions to the population, like, we want to do this, is this actually a great idea, how do you think about it? Because a lot of it is about ethics. So you kind of need to sell it in general to the politician, like, this is a great forum to actually get some information from the population and basically to get re-elected, because the what's in it for me works for healthcare workers, social care workers, but also for politicians as well.
Well, we'll move on, folks. I mean, look, I know you'll have questions, but hopefully if we can't talk them here, we'll meet in the corridors of power outside. The third question then I'd like to ask Sumit. There was a lot of conversation around doing things for people and doing things to people. So how do we turn what kind of appears to be a passive population in communities that are used to having services delivered to them into proactive approaches and often reversing long-term poor and established practice?
Yeah, that's a great question. Thanks. I think one of the things that we've been talking about is community empowerment, amplifying voices, representation, and I think we're missing one of the things that we haven't talked about is around capacity building. How do we ensure representation here at the table or there at the table? I mean, for my work, I would have loved for Janet or Ralph to be able to be here either in my place or next to me. Unfortunately, one of the challenges that we have is with the Sioux Lookout First Nations Health Authority and international travel. It doesn't really work. I'm hoping they might travel to Calgary for the Integrated Care Conference because it's in Canada. But I think the representation of having I guess it's a social justice thing. Having our community members at the table when we're having these conversations, I think is the way to go. We talked about, one of the presenters talked about building bridges. So we're in that intermediary step, right? We're building bridges. But what's on the other side of the bridge, I think, is what's important. And it's where we're all together and having our voices not just amplified, but having the voices right there. And then.
Thank you.
I've got one here actually for Melissa, if that's okay. And to the others, there's a few questions that are coming in around accountability and how you hold providers accountable and how, as a network, you do manage to get that equity of voice from both the community but also from the provider side.
Yeah, thank you. The interesting notion about an Ontario Health team is that in its current construct, there is still accountability agreements with our current ministry. So a lot of this work is actually around collective impact and wanting to do it together, which is even more challenging in the current landscape. So I think that at the provider level, at the community level, people want to see change. So there is an exciting opportunity to think about that different. And kind of going back to what all these presentations talk about is that the status quo is not working. The engagement of communities has not been well done in the past. This to me is an exciting opportunity. How do I hold people accountable to that? Well, we hold each other accountable when we come around the table and talk about what we want to do. And that comes in various forms, whether that's a terms of reference where we have a mutual agreement, but staying open and flexible to understanding how that could change. So, and I saw a question I'll quickly say on the board level, how do we have an inclusive kind of governance structure? From our standpoint, we've built that in across a number of different structures. Our board follows a pretty intense diversity matrix, but no board is going to be perfect. There's no way we can represent every single person that we need to. I very much really think the structures and advisories underneath a board are the most important. They will inform the decision making. A board is, hands off, eyes in. So including, the equity lens in all of the working groups only helps a board continue to understand to promote that at that level.
Thank you. Well, I have one last one here if I just wanted to get a direct question for Pauline. How did you rebalance homelessness from solely a housing crisis to one of a comprehensive health and social one?
Can you repeat that question, please?
How did you rebalance homelessness from solely just being about the housing situation to being a more holistic approach to that individual about their whole?
Well, I mean, I think it's so central, but obviously it's not just about homelessness. I mean, by having a really comprehensive approach that meets the patient or the person where they are and what matters to them, you realize that there are so many pieces around becoming homeless, some of it having to do with inadequate addressing of mental health challenges, some of it having to do with substance use, often having to do with social isolation. And so I think that by really looking at what matters to the people who are in that situation and becoming extremely broad-based in how you address that, you go way beyond homelessness.
Mm-hmm. Thank you.
We're out of time, folks. Again, it's quite difficult for me. Normally, I'm usually the one in the middle of the conversation and prompting kind of more questions than answers usually. I think it's very interesting that we use different language to say the same things. And in each of the presentations, there were kind of common themes which were recurring. How do you make participation meaningful? How do you affect change? How do you affect it at an individual level, at a community level, and at an organizational level that then allows people to take responsibility for themselves in their communities? And how do we then collectively support that, and how do we measure it, I think is a key challenge for us. Great. So thank you very much, folks.
Thank you. Back in here in 20 minutes for the Northern Irish session.